Okay, this video is to talk about the diagnosis of gastroesophageal reflux disease. First of all, I'm sorry for the preoccupied sheet with these lines. Okay, I just I can just erase them. Okay, let's start. The diagnosis of the gastroesophageal reflux disease depends mostly on the age of the child, whether he is an infant or a toddler, okay, or is he older children or adolescent. Okay, in the difference in symptoms in infants and toddler and the older children is the reason behind subdividing the diagnosis of the gastroesophageal reflux disease into these many groups. Okay, in infant and toddler we have no obvious symptoms, okay, no specific symptoms for gastroesophageal reflux disease. Okay, so we can check the response to proton pump inhibitors, for example, because we have no symptoms to depend on. So the first line diagnostic test is the esophageal pH monitoring, a 24-hour esophageal pH monitoring. Actually, it's the diagnostic test and the gold standard for gastroesophageal reflux disease in both infants and toddlers and the older children. Okay, so the diagnostic test is esophageal pH monitoring. Actually, it is a probe that applied to the lower esophageal sphincter for 24 hours, and this probe can detect the or measure the duration and the frequency of acid reflux episodes. What do we mean by acid reflux episodes? Every time we have below 4 pH, okay, for a minimum period of 15 to 30 seconds, we have a pH or a reflux episode. Okay, the pH probe that applied to the lower esophageal sphincter in the esophageal pH monitoring, it can detect or measure the presence of these episodes, okay, and can measure what we call reflux index and symptom index. What is reflux index? Reflux index is the total time or the percentage of the total time we have reflux episodes. What do I mean by this? For example, in 24 hours, if we have 10 episodes, okay, each episode, or 100 episodes, okay, each episode is of, for example, 2 minutes duration, then what is the total time of episodes? You have to multiply the frequency of each of the episodes by each episode duration, okay, which is in this example 2 minutes, okay, and the frequency is 100 times. So the pH monitoring esophagus probe, okay, can measure the total time, percentage of time for these episodes. It is normal to have 12% reflux episodes in 24 hours in infants. Okay, so it is normal to have 20% of the time or of the 24 hours reflux episodes in infants, but in older children it is only normal to have 6%. Why is it higher in infant? Why do we have more acceptable period of time to have reflux in infants? Because in infants, physiologically we have shorter esophagus, we have different position of the baby, and the baby is not moving as in older children. So, okay, so and the position of the esophagus, all these things contribute to higher rate of esophageal reflux, physiological esophageal reflux in children. I think this video will help you to understand what is 24-hour esophageal pH monitoring. Let's watch it together. Okay, so okay, I'm sorry, let's just start from here. Okay, so this is the probe introduced into the mouth, okay, through the mouth into the esophagus, specifically the lower esophageal sphincter, and when it is put in this place, it can measure the things I talked about, the reflux index. What also it can measure, measure the symptoms index. What is symptom index? It is the ratio or the total time of having Gerd symptoms, okay, during the reflux attack. Okay, so this is the esophagus, this is the stomach. If we have a reflux, okay, and during this reflux we have a symptom, for example heartburn, this instrument will count it as the first time. Okay, so if we have another episode of reflux and other episode of symptoms, it is the second time and third time and fourth, okay, and so on. So it measures the total time of having symptoms during the reflux attack. If we have more than 50% concordance between the reflux and symptoms, then this is a significant measure and we have to take care of it. So this is the gold standard to diagnose gastroesophageal reflux disease. Okay, now let's move to the other case. If we have older children and adolescents, in older children and adolescents we have more clear history and physical examination. We have more specific symptoms for gastroesophageal reflux disease. So the symptoms, history, physical examination are sufficient to diagnose the gastroesophageal reflux disease, and the response to therapy will be clear. Okay, so we use what we call empirical trial of acid suppression. In empirical trial for acid suppression, we give proton pump inhibitors for 4 weeks. Okay, if we have a response, okay, then we can highly suspect gastroesophageal reflux disease. If we have no symptoms, okay, sorry, if we have no symptoms, then we can rule out gastroesophageal reflux disease in a lot of cases. Okay, so after the empirical trial of acid suppression, if we suspect gastroesophageal reflux disease, we should do 24-hour pH monitoring that I talked about. Okay, so it's the gold standard in both ages. Okay, after that we can do endoscopy and biopsy, and the indication of endoscopy and biopsy are in the cases of dysphagia, anemia, blood in stool, weight loss, voice changes, if we suspect the presence of esophagitis, esophagus or esophageal cancer, for example. Okay, so this is the indications for endoscopy and biopsy. Okay, it can detect the presence of esophagus, can detect the presence of esophagitis. How? By the presence of visible breaks in the esophageal mucosa. Okay, so it can detect the esophagitis. Pallor, erythema, and change in the vascularity of the esophagus actually are not specific, okay, or sensitive things to observe for gastroesophageal reflux disease. If we have no histological changes in the biopsy of the endoscopic examination, we can't rule out gastroesophageal reflux disease, because we may have Gerd without clear pathological changes. Okay, now I want to show you how to apply Gerd by this endoscopy by this feed. Okay, so this is the endoscopic procedure. They introduce a lightened tube, okay, to the lower esophageal sphincter, and in the lower esophageal sphincter they can take a biopsy, okay, and the biopsy can show us the presence of esophagitis, esophagus. Okay, sometimes they can't see anything by endoscopy, but the biopsy shows that they have esophagitis, for example. So this is the importance of endoscopy and biopsy if we suspect esophagitis, esophagus, or some kind of cancers. Okay, so I told you that we can't exclude gastroesophageal reflux disease if we have nothing in the biopsy. Okay, we have to do what we call motility studies, the esophageal manometry. Sometimes we have problem in the movement of the esophagus. We have no peristalsis like in achalasia, okay, and that will predispose for gastroesophageal reflux disease, because the delay in esophageal emptying, delay in gastric emptying, and so on. And again, motility studies are not done in every patient. Okay, it has some indications. We have also gastric nuclear scintigraphy. And gastric nuclear scintigraphy is an imaging study that can show us the movement of food from the stomach and the emptying of the stomach and the reflux sometimes. Okay, actually the importance of this study is to detect the presence of pulmonary aspiration, okay, or the respiratory complications of gastroesophageal reflux disease. Actually, it is not recommended for Gerd per se. Okay, it is not a routine test for Gerd. We can use it sometimes if we suspect respiratory problems or a delay in gastric emptying. One of the most important tests, okay, but are not diagnostic for is not this diagnostic for gastroesophageal reflux disease, is the barium contrast study. It may help us. Okay, the most important usage of it is to detect the anatomical abnormalities like the pylorostenosis, for example, like the malrotation. Okay, but the bad news about the barium contrast is the presence of false positive and false negative values. What do you mean by false positive? Sometimes we have a reflux in barium contrast, okay, but we have no disease, okay, just gastroesophageal reflux, physiological, and the barium study cannot distinguish between the physiological and the pathological gastroesophageal reflux. We may have also a false negative value. What do we mean by false negative value? We may show no reflux in barium study, but the fact we have a gastroesophageal reflux disease. Why? So we were not able to see this reflux because the barium contrast study is some minutes study. Okay, it has short time to detect the presence of abnormalities, so it will not be able to diagnose gastroesophageal reflux disease. The only use of this barium contrast is the anatomical abnormalities detection, like in stricture and other things I talked about. I want to show you other video talk about the barium study. Okay, so I think this is barium swallow. They apply contrast, okay, into the esophagus and the stomach. Okay, it detects if we have stricture here, for example. If there is reflux, it may be shown, but it may be physiological reflux, so it is not diagnostic for gastroesophageal reflux disease. So this is the barium study. So this is all about the diagnosis of gastroesophageal reflux disease. Remember that it depends on the age of the patient. Okay, the esophageal pH monitoring 24-hour is the diagnostic test. Nowadays we can use what we call combined multiple intraluminal impedance. Okay, the combined multiple intraluminal impedance is also an pH monitoring device, but the good news about this device that it detects not just acids but also weak acids and weak bases and other material by analyzing the electrolyte reflux into the esophagus. So this is the benefit of a combined multiple intraluminal impedance over the esophageal pH monitoring 24 hours esophageal pH monitoring. It detects other things rather than the acid reflux, alkaline reflux, and other things. Okay, so thank you very much for watching this video. In the next video I'm going to talk about the treatment, the complications of gastroesophageal reflux disease. Thank you very much.